So hi everybody, it's really nice to see you all, or to know that you're all here, I guess. I can't quite see everybody. And welcome to the second webinar that's part of SRUK's Raynauds Awareness Month. Today we have with us Professor Ariane Herrick, who is from the University of Manchester, and she's going to be giving a talk on how to manage your Raynauds phenomenon and some of the complications that can arise from that. The presentation will be around about 25 minutes, and then afterwards we're going to do a Q&A. So on your screens you should all have access to a Q&A button. I can see someone's already popped a question into there, which is exciting, and you're welcome to add questions in at any point across the talk. We'll go through them all at the end, but if Ariane says something that you want to pick up on or something pops into your head partway through, you're welcome to add that at any time. Be aware that that's a public forum, so even though I don't think you can all see the questions that are being asked, I must admit I'm not certain on that one, don't add any particularly kind of private or personal details, because we can't comment on an individual medical kind of case. Now I'm sure Ariane probably doesn't need much introduction to a lot of you, but for those who don't know, it's my pleasure to introduce her today as one of our expert speakers. So Professor Herrick is a professor of rheumatology and a consultant rheumatologist at Salford Care Organisation NHS Foundation Trust, and she's also one of SRUK's 2 vice presidents. Ariane's research focuses primarily on Raynauds, with a particular interest in nail fold capillaroscopy and digital vascular structure and function. So Professor Herrick, thank you very much for your time today. I'm going to hand over to you to get started.
Well, thank you very much to Emma and to SRUK for inviting me to participate in this webinar. It's great that so many of you are here, and I'm going to talk about the management of Raynauds phenomenon, that's the treatment of Raynauds phenomenon, and also of some related conditions, although I would stress that the related conditions, directly and indirectly related, only refer to people with systemic sclerosis or scleroderma. So some of you will perhaps not be quite so aware of the other issues. So I'm going to cover the different points in this slide in turn. First of all, I'm going to talk about the treatment of Raynauds phenomenon. I'm then going to talk about the treatment of finger ulcers, ask a question about treatment for calcinosis, and about treatment of finger contractures, that means bent fingers, and of skin thickening. And finally, I was asked to touch upon the treatment of telangiectases. These are little red spots, which some of you will be aware of, which can occur in the face and the hands, especially in people with scleroderma. So first of all, I'm going to talk about treatment of Raynauds phenomenon. Now, I know that there was a recent webinar by Dr. John Pauling who covered the different aspects of Raynauds phenomenon. And so for those of you who attended that, you will know all about Raynauds phenomenon already. And of course, many of you know all about Raynauds from your personal experience. But we're going to focus now on how we treat it. And there are different aspects to the treatment of Raynauds phenomenon. And I'm going to go through each of these in turn. First of all, it's important to decide what the cause of Raynauds phenomenon is, because there may be something that will be amenable to treatment in its own right. For example, primary Raynauds phenomenon, which is a common type of Raynauds phenomenon, which affects around 5% of the population, there isn't an aggravating cause. And similarly, in patients who have Raynaud's secondary to scleroderma, or secondary to, I'll use the term scleroderma, but by scleroderma I mean systemic sclerosis. By those who have Raynaud's secondary to scleroderma, there isn't any particular cause that we can remove to treat the Raynauds phenomenon, but sometimes there is. For example, some people are on certain medications which can aggravate Raynauds phenomenon. Some people might be using vibratory equipment, which use of which could be curtailed. And occasionally there are smaller print diseases which cause Raynauds phenomenon, which can be treated in their own right. So the first thing to do is to establish the cause of the Raynauds phenomenon and to decide whether any treatment is indicated for that. So the next step in treatment, and this really applies for everyone, are general measures. And I can't emphasize the importance of these, and they're very often rather forgotten about, but it's tremendously important to keep generally warm. And that doesn't just mean wearing warm gloves or socks. It also means dressing warmly, wearing a nice warm hat in temperatures as we're experiencing at the moment. And there are various different ways that you can keep warm. There are hand warmers and different types of gloves, which many of you will know about. It's important if you smoke to try to stop smoking, because we know that smoking is bad for the blood vessels as well as for several other reasons. And so if you have Raynauds phenomenon, there would be a special emphasis to try to stop smoking. And then we come to drug treatment. Now, not everyone with Raynauds requires drug treatment, but many people do. And certainly most people in whom Raynauds is secondary to scleroderma will very often require drug treatment. Now, you have to remember that these medications work by widening the blood vessels. And they do this not just in the fingers, they do it generally. So these medications all have the propensity to cause what we call vasodilatory side effects. They can all cause a bit of a headache or dizziness or a flush in the face, but they may well not. But we do need to be careful because many patients are very sensitive to them. And so I think as a generalization, it's always important to start in a low dose in case you are very sensitive to these agents, and then to gradually increase the dose up to what we would call the maximum tolerated dose. And the first line treatment by most clinicians are a group of drugs called calcium channel blockers. And examples are nifedipine or amlodipine. And my preference is to use a sustained release. That's a long-acting preparation because in my experience, it's better tolerated than a short-acting preparation, although some people do prefer the short-acting ones. So that would be my first choice of medication for Raynauds. And then the second choice, there are a number of different types of medication which can widen blood vessels. But it's interesting, and I'm going to come back to this, but increasingly used are the so-called phosphodiesterase inhibitors or PDE5 inhibitors. And one example is sildenafil or Viagra, which is now being used increasingly, especially in people who have Raynauds secondary to scleroderma. And they're probably quite effective, the phosphodiesterase inhibitors, and I'm certainly recommending them much more than I used to. A lot of general practitioners are not happy to prescribe them because they're being prescribed out of license. And so in that case, we prescribe them from the hospital, but they're increasingly used. And there are a number of other treatments which improve blood flow. For example, intravenous, I'll come to intravenous iloprost infusions in a minute, but there are other treatments. For example, drugs called angiotensin blockers, for example, losartan, or one or two other ones, which can improve blood flow, but none of them have a great deal of evidence base behind them. And I've put intravenous iloprost infusions in brackets because I personally seldom use them for Raynauds in itself. If Raynauds, and we're going to come to this, has led to digital ulcers, if it's been as severe as that, then I would recommend iloprost. But we don't generally use it for Raynauds alone, although we sometimes do in people with bad Raynauds, especially secondary to scleroderma. And this necessitates coming into hospital for daily infusions of a substance called iloprost, which some of you will be very familiar with. I think it's important to remember that if you don't tolerate one drug, for example, if you try, for example, nifedipine or amlodipine, and you either don't tolerate it or you find that it's not effective, then you can try another one or you can add it in. So I think it's important, and we do use combination therapies quite a lot. So it's important not to give up at first try, but to keep persevering. And this slide here shows a paper that we published some years ago, and I've chosen to mention this deliberately because this was published 7 years ago now. And you could say, well, that's a little bit out of date. And it is out of date, but in a way that's good because it shows that we're making advances. And in this group of clinicians for the UK Scleroderma Study Group, all of us are interested in Raynauds and scleroderma, and we met up and we formed these pathways for different aspects of the digital vasculopathy. That means the vasculopathy means problems with the blood vessels, and digits as fingers and toes. So the problems with the blood vessels. So we had different charts for the different manifestations of digital vasculopathy. And the first one is Raynauds phenomenon. And I'm not going to go through all the points in this slide because I've already mentioned them previously, but I just want to really underscore how we have made advances, because this was back in 2015, as I mentioned, and all the time initially said up at the top, we want to identify whether there's an underlying cause. And for example, one rare cause is a condition called cryoglobulinemia. That's a hematological condition that can be specifically treated. And after lifestyle measures, we start these different medications in the green boxes. And I apologize for the abbreviations which were in the flowchart, but CCB is calcium channel blockers, or angiotensin II blockers for ARBs. But the thing that's changed is what I've shown with the yellow star, because right down at the bottom of the chart, after we tried intravenous iloprost, which is an example of a prostanoid, so even after we'd really gone to great lengths to try and improve the Raynauds, we then, only then, could we prescribe this group of drugs called phosphodiester inhibitors. Now we have much readier access to these, and so these have moved right up the pathway so that they follow after calcium channel blockers. And in my opinion, that's been one of the big advances in the treatment of Raynauds phenomenon over the last 3 to 5 years, is the increasing availability of these drugs called phosphodiester inhibitors, which are really quite successful in treating Raynauds phenomenon in a lot of patients. I know many patients who have really found that they're very beneficial and are very pleased that they've started them. And there are some other aspects of management that I won't go through now, but I'm very happy to discuss after during the Q&A session. So now I'd like to move on to treatment of finger ulcers. Now I did previously give a webinar, it's over a year ago now, that some of you might have attended, and it was on the subject of finger ulcers or digital ulcers, digital meaning fingers or toes. So I'm going to focus this time on the treatment aspects. And I think it is worth revisiting this, because even though we discussed treatment towards the end of 2020, I think it's exciting, because I think there have been some advances in the treatment over that period of time that I'd like to share with you. But we will recap generally on the treatment of finger ulcers. Now, I would like to reassure those of you who are here with primary Raynauds phenomenon that primary Raynauds phenomenon does not progress to finger ulcers or to the other problems which are shown on the slide. But if you have scleroderma or systemic sclerosis, then unfortunately there is a possibility that you will develop a finger ulcer. And in fact, probably around half of people with scleroderma do go on to develop finger ulcers. So it is very relevant, and it's an important part of our management. And this slide here shows the different aspects to the treatment of finger ulcers. And there are a few gold stars popping up, which will show you things that have actually changed since we last discussed this about 15 months ago or so now. So I'm going to come back to this slide, and here you see examples of finger ulcers. These are nasty ulcers. A lot of ulcers aren't as troublesome as the ones shown here, but this is an ulcer typically at the tip of the finger here, and that's a common site for ulcers. And this is another common site of an ulcer over what we call the extensor aspect of this finger joint here, because the finger was a little bit bent, as we'll see later, and that stretches the skin and it can make it prone to ulcers. And this was a very nasty ulcer here, which actually was infected. There was bone infection underneath that, which was very difficult to treat, but it was treated successfully with a prolonged course of antibiotics. So the first part of management is very important, and that is to seek medical advice early. If you get an ulcer, tell someone about it, because it's very difficult, you know, for general practitioners who see very little scleroderma to understand sometimes the importance of these lesions, because they often don't look very much, but as many of you know, they can be extremely painful, and if they're left untreated, they can become a major problem, as shown especially in the one at the bottom right there. So how have we addressed this? And a gold star here, because I think there have been certain learning points from the pandemic. And we always tried at Salford Draw, where I work, to operate an open door policy for finger ulcers. And we would tell people to contact our helpline if they got a finger ulcer, because we're always happy to see them. A lot of people weren't so happy to come up during the pandemic, and very understandably. We were trying not to encourage people to come up to the hospital at that time. And so we set up a dedicated email address so that people could show us photographs size of their ulcers. So this young woman sent in this photograph, which really looks quite nasty. There's some pus, you know, here underneath this area of ulceration, which is becoming a little bit black and not very nice looking. And that was very useful for us because it gives us added information to just what we'd have over the telephone. And in fact, this patient had a surgical cleaning up or debridement just, I think it was 3 days after the phone call and the photograph was sent. So I think it's shown, you know, how we've moved forwards quite a lot now, and we now use this facility quite a lot so that we can judge the ulcer better than we would have been able to just from a phone call. So I think that's been good. So coming back to the same slide, as I say, very important to see medical advice early. Wound care is an important aspect of management. For large nasty ulcers, we would involve our skilled nursing staff and tissue viability staff sometimes to aid wound healing and advise on dressings. Pain relief is a huge part of the management because, as many of you know only too well, these ulcers can be excruciating, they can keep you awake at night, they can really completely destroy quality of life. So very often you do need very powerful painkillers, sometimes morphine, you know, in the short term. I mean, obviously, hopefully that wouldn't be for very long, but you may need something quite strong depending on the severity of the ulceration. Another aspect of management is antibiotic therapy. Now, these ulcers shown here on the right are very infected looking. You can see the pus coming out of these ulcers, very nasty ulcers, but they did treat, they were successfully treated with prompt antibiotics and with cleaning them up with good wound care. So I think even though they look very bad, they will actually very often heal with appropriate management, but it is important. And you know, really, if you have an ulcer that might be more painful or a little bit red, and there's any questions of infection, then I would have a low threshold of having an antibiotic. And then an important part of management is to improve blood flow, and that's along the lines of what we were discussing under the treatment of Raynauds phenomenon, just to optimize treatment with, you know, for example, these drugs called calcium channel blockers or phosphodiesterase inhibitors. We have another drug that some of you will be familiar with called bosentan, and I'll come back to that, but that is available now to prevent recurrent ulcers in people with scleroderma. So if you're prone to ulcers, then we would probably commence bosentan. It used to be very difficult to get, but it's now much easier to obtain now for patients. And so that would be another aspect of management, additional to all the other aspects of management. And sometimes if there's a big problem, for example, the ulcers shown here, if they were really problematic, we probably would suggest an admission for intravenous iloprost infusions. And we do this for nasty infected ulcers. And in fact, we just started someone over the weekend here an intravenous iloprost infusions because they had a nasty infected fingertip ulcer, which in fact surgeons had to treat and removed a lot of pus. And then we started intravenous iloprost to try to improve the wound healing. Because surgical procedures can be helpful. Most patients will not require surgery, but sometimes there will be a need for a surgical procedure. And in my experience, the commonest surgical procedure is just this procedure called debridement, really just to clean up the ulcer, remove any dead tissue, and release any pus which might be there, because the pus needs to be released. So in that case, it does require debridement. And here's an image which I did show last time, for those of you who attended. And I'm just going to run through this again because this was the second of the flow charts from the paper that I mentioned earlier, and from the UK Scleroderma Study Group. And I'm not going to go right through it because I've really discussed it already. That is making the diagnosis early, thinking about if there's anything else that we need to treat, for example, infection, or whether there's any problem with the larger vessels which needs treated, and optimal wound care. But the thing that's changed here, and I'll show this in the next slide, is that when this was written, which was 7 years ago, the thing was to optimize the medication, the oral medication, the calcium channel blockers, the sildenafil or whatever, and probably give intravenous iloprost or another of these so-called drugs called prostanoids, because there are one or two other ones. And while we still would give intravenous prostanoid as an early step in someone who had an acute ulcer that really wasn't healing, if it's a more chronic process or for recurrent ulcers, then there are more treatments that are available early. And we would certainly, as I said with the Raynauds flowchart, we would certainly use this type of drug called a phosphodiesterase inhibitor or a PD5 inhibitor. We would use that much earlier. And we would also use this type of drug called an ERA or an endothelin receptor antagonist. And the one that we use is bosentan. We would use this now much earlier in the pathway to try to prevent the need for requiring hospital admission for the intravenous iloprost infusions. Because, we obviously want to try and keep people from the necessity of having to ask them to come into hospital, which nobody likes to do. And especially in the COVID era, we really want to minimize hospitalizations as much as possible. So I've added a new box. This box on the right-hand side called botulinum toxin injections wasn't in the 2015 paper, which I mentioned. So I've cheated a little bit and added it on because we tend to get asked quite a lot about botulinum toxin injections, that's Botox injections. And it's an interesting point because there have been several papers in literature over the last few years talking about Botox injections for digital ulcers and perhaps to a lesser extent for Raynaud's. And it's difficult to know just how effective they are because we do need to have more studies just looking at efficacy. But there have been a lot of anecdotal reports suggesting they're helpful. And certainly the hospital where I work, the hand surgeons that I collaborate very closely with do use Botox, usually in patients who are having a debridement, and they might put in some Botox at the same time. Sometimes they will just give Botox. So I think it's interesting, and I think it's difficult to know how effective it is, but there's a theoretical rationale for it, and it is something that I think has changed because I think this is becoming much more available over the last few years. So the next slide before we leave digital ulceration is, I think this is quite exciting, and this is new, a gold star, since I last talked on digital ulcers. But NHS England now has got what we call a commissioning policy for the treatment of digital ulcers, which has changed since its last commissioning policy. And it now has placed sildenafil, that's the phosphodiesterase inhibitor, that's Viagra, and bosentan, which I mentioned, which is a license for preventing recurrent digital ulcers. These are put before intravenous iloprost infusions. So I think this is new. And so I think it's good because I think it means that there's much more accessibility to these oral treatments, which previously were difficult to obtain. And what we hope is that this will prevent, patients having to come in for intravenous iloprost infusions. So I think there have been, practical steps forward in the treatment of digital ulcers in the UK since we last discussed this. So now I'd like to change tack a little bit and talk about calcinosis. Now, calcinosis is something which many of you are only too familiar with, which can occur in people with scleroderma. Again, this will not occur in primary Raynauds phenomenon. And I'm afraid that I've asked this as a question, rather than talking about treatment, because unfortunately, again, as many of you know only too well, despite many different suggestions in lots of different papers and literature, I think most doctors would agree that there isn't a medical cure at the moment for calcinosis. We can't prevent it happening, and we can't treat it medically when it occurs. So that's unfortunate, and it's something that we are trying to do research on to try and develop a treatment which will reduce the burden of calcinosis. But at the present moment, it remains a very major problem. And here you can see calcinosis of this finger here, which you can see, and here the calcinosis is white, here chalky material is actually coming out through the skin. And calcinosis is very well demonstrated on X-ray, and you can see this patient here who has calcinosis of many different fingers. And you can see by the white opacities on the different fingers. So because there isn't a cure, it doesn't mean that we can't do anything about calcinosis. It's appropriate to mention it in a talk on finger problems because fingers and the hands are the most common site affected. You can also get calcinosis, many of you know, over the elbows, over the knees and other pressure points. But I think one important aspect of management is, as with finger ulcers, to have a very low threshold for giving an antibiotic if there's any suggestion that calcinosis is infected. And this is particularly likely to happen when, in the patient on the bottom left, the calcinosis ulcerates through skin. And we can consider surgical debulking. And we do refer quite a few people to the surgeons, but you have to remember, if you do have surgery, that surgery will never remove the calcinosis. It will only debulk it. And unfortunately, the calcinosis can regrow. But nonetheless, it can buy a little bit of time. You have to have, preferably a surgeon who's very familiar with systemic sclerosis or scleroderma, because the blood supply is poor to the fingers. So you can have problems with surgery because of the poor blood supply. So it has to be very carefully considered vis-a-vis the pros and the cons of calcinosis. But sometimes surgical debulking is appropriate, and we do consider that. So the fourth thing that I was asked to talk about was treatment of finger contractures and of skin thickening. And again, there's a question mark here, because our treatments aren't really as effective, unfortunately, here as what we would like them to be. While there are established treatments for Raynauds phenomenon and for finger ulcers, although they're not as effective as we would like them to be, and we want to continue to try to develop better treatments, there are treatments. But for calcinosis and for these contractures, I think one has to be completely honest and say that there isn't a cure at this moment in time, although there is a lot of research going on. But these contractures, and you can see this patient here is trying to put the palms of her hands together, but is unable to do so because the fingers are bent. And if you look carefully, you can see that there are one or two very small incipient ulcers developing there, and that can happen over these what we call the extensor aspects of the fingers, because the skin is stretched and is liable to ulceration. So not only do you have the problems of the very limited finger movements and all the associated pain with that, but you can also, on top of it, the contractures get finger ulcers. So they are a very major problem. And that's why we advocate stretching exercises, not because we think that will cure a flexion contracture. These are called flexion contractures because the fingers are contracted in what we call a flexed position, a bent position, but because we want to maintain the range of movement that a person has. And so I think it is important that you continue to do your stretching exercises. But the treatment really is of the underlying disease. And so that really means trying to treat the underlying skin thickening. And this patient shown here had diffuse cutaneous systemic sclerosis, diffuse subtype, when the skin involvement progressed, to involve not just the fingers, but other parts of the body. And although finger contractures, excuse me, can occur in limited cutaneous disease, they're most commonly seen in patients with diffuse disease, and they often occur early. And so we really have to treat this early diffuse disease, quite aggressively. And most clinicians would recommend a drug to suppress the immune system, such as mycophenolate or methotrexate, which some of you will be familiar with, in an attempt to try to slow down the rate of the skin thickening, although it's difficult and our treatments aren't as good as we would like them to be. But for the contractures per se, once they are formed, then unfortunately they tend to persist. And so even though we know that in diffuse cutaneous disease, some years down the line, the skin can thin and the skin can no longer appear thickened, unfortunately, the contractures will persist. And that's why it's so important to get an effective treatment for early diffuse disease, so that we can try and stop the skin thickening. And if we can stop that, then we will stop the contractures happening. But unfortunately, at the present moment, these contractures do often form. And I think that all we can say is that if you do have contractures, I think an important part of management is not just the stretching exercises, but also to see the occupational therapist, because their skill is to try and minimize the impact of the condition. And I think that's very important. So finally, I want to talk about telangiectases. Now, some of you will know, again, very well what telangiectases are. And here we see a picture of a patient with many telangiectases. And you can see these little red spots, which are very prominent. This patient has a lot on her fingers. This is a little bit unusual to see as many of them. And the patient also has multiple areas of calcinosis, which we discussed earlier. Interestingly, didn't do very much in the way of skin thickening. This patient had limited cutaneous variant of systemic sclerosis. And you know that they're telangiectases because if you press them, if you press a telangiectases with your finger, and that it will disappear. And if you remove the finger, it won't be there, but then the blood will come back. So within a few seconds, it will reappear. But the treatment of telangiectases is challenging as well. Now, most people are more worried about telangiectases of their face because they're very disfiguring, and as many of you will know, they can be very obvious. And people tend maybe not to be quite so concerned about telangiectases of the fingers, but they too, as in this patient, can be really quite a problem. And there are various camouflage techniques that can be recommended. We often refer patients to changing faces, which can give advice on camouflage techniques. And I want to just talk a little bit about laser treatment, because it is possible to advocate laser treatment. And it's interesting because there has been very little research conducted into treating telangiectases. And I'm just going to show you a slide from a paper that we published now about 8 years ago. Wim Hof, who some of you will know, was the first author in this paper. And this was a study which was funded by, well, what was then RSA, and now SRUK. And what we did was we treated patients with telangiectases, mainly telangiectases of the face, because they tend to be the ones, as I said, that are most upsetting. But they would be treated with either a technique called pulsed dye laser, which is a more conventional approach, or another approach called intense pulsed light. And this patient, and so one side of the face was treated with one and one with the other. And in fact, both treatments were quite helpful in reducing the degree of the telangiectases. And you can see this here. This was at baseline and this was after treatment. And this picture here at the bottom shows a telangiectases picture through what's called a dermatoscope, and it magnifies up the surface of the skin, and you can see the telangiectases here. And this shows the distortion of the little blood vessels that are abnormal in scleroderma and which cause the telangiectases. And you can see that after the treatment on this occasion, the telangiectases looked a lot better. But they can reappear afterwards, and not everyone benefits from laser treatment. And so I just put it out there as something that I think we are interested in, and we don't want to neglect telangiectases, because they are a very major source of concern for many people. So just to wrap up, we've talked about the different points in this slide here. We've talked about the treatment of Raynauds phenomenon and finger ulcers in the context of people who have scleroderma. And we've shown that there have been advances over the last 5 to 6 years, as we saw with the flowcharts from that earlier paper. But there have also been advances in finger ulcers, even just since we discussed this last time about 15 months ago. So I think, although progress isn't as fast as we would like it to be, we are getting there. We remain challenged by finding an effective treatment for calcinosis and for the finger contractures. And so at the moment, we really have to treat these as best we can, knowing that there are limitations in our approaches. And we've just talked a little bit about the treatments that are available for telangiectases. I'd like to conclude by saying that if we talk first about the Raynauds phenomena, there are a lot of different aspects to the care of Raynauds phenomenon. So it's not just drug treatment. There are all sorts of things, keeping warm, remembering to wear warm socks and boots in this weather. In patients with systemic sclerosis or scleroderma, a number of other finger problems can occur, and to some extent they interrelate, because in one way or another they tend to be related to the poor blood flow or to the thickening of the skin. Ulcers and calcinotic areas can both become infected, and so you need to be very careful if you have an ulcer or an area of calcinosis. If it gets red or angry or more painful, do discuss with your medical team about whether you might require an antibiotic. And just to finish, that although we don't have such good treatments as we would like, we are making progress, and there are a number of research studies ongoing to try and improve things for you and to develop safe and effective new treatments. And finally, just like to say thank you to all of you for listening, and to SRUK for hosting the webinar. And I'm very happy to take any questions.
Thank you very much for your presentation, Ariane. That was fantastic and very comprehensive. So we've had a lot of brilliant questions that have already come through, and I can see more coming in now that the presentation's come to an end. So I'm going to start off with the first question that we had, which was from a lady called Maya, who asks, are Raynauds and arrhythmia associated?
Yeah, well, thanks very much. Well, as always, these questions are sometimes a little bit more complicated than they sound. So arrhythmia, for some of the those of you who might not know, arrhythmia means an irregularity of the heart rate. And I mean, I think there isn't any direct association between Raynauds phenomenon and arrhythmias, but they could be indirectly associated, because if Raynauds is part and parcel of systemic sclerosis, if someone's Raynauds is secondary to systemic sclerosis, then by dint of having systemic sclerosis, then they are at increased risk of arrhythmias. And so there could be indirectly related in that sense. And we also have to be careful in a patient who has an arrhythmia, for whatever reason, be it related to systemic sclerosis or be it for another reason, because arrhythmias can occur for a number of different reasons, then you have to be a little bit careful about the treatment of Raynauds phenomenon, because some treatments for Raynauds may not be the best thing, depending on the nature of the arrhythmia. So you have to be a little bit careful about that.
Thank you. From Lauren. Lauren has said, I have swelling and pain in my hands on top of primary Raynauds for the past 2 years. I've had all the tests for arthritis and scleroderma, which came back negative. Do you have any advice on how to manage this?
Yeah, well, thanks. All right. I obviously can't comment on your individual case, but to take a general point about someone who has swelling of the hands in the context of Raynauds phenomenon, it could be an unrelated problem. Hand swelling can occur for a number of different reasons. You can have, and it depends also whether it's just the fingers or whether it's a finger and the whole hand. If it's just the fingers, we sometimes talk about puffy fingers, and we have to be a little bit careful about people who have puffy fingers with Raynauds, because occasionally it can be an indicator that there might be some underlying cause for the Raynauds. So I think it would be important to, let one's doctor know about the finger puffiness. It's also possible that it's completely unrelated. I mean, you can get hand and wrist swelling for a variety of different reasons. Some of them related to the musculoskeletal disease. So it's difficult to say whether they would be related or not.
Thank you. Vicky has asked whether it's, or actually she has asked what your opinion is on the fact that she has found it stated that Raynauds could be linked to a lack of vitamin E. Is that something that you're aware of?
Sorry, I'll just get my phone off the hook. Sorry, I'll just I should have put my phone off the hook. Never mind. So about vitamin E, there has been a little bit of discussion about vitamins and vitamin deficiencies and Raynauds and systemic sclerosis. I'd need to look up the specific literature about vitamin E, I have to admit. There was quite a lot of interest in vitamin C quite a few years ago. Some patients with systemic sclerosis were found to have somewhat low levels of vitamin C, but that wasn't by any matter of means a universal finding. And I think the important thing is to have a balanced diet, really. I don't personally advocate vitamin supplements, but I think it is important to have a good diet.
Speaking of specific medications, does HRT make Raynaud's symptoms worse? And that is a question from Maggie.
I'd be a little bit surprised if HRT was to make Raynauds worse. Again, these questions are sometimes a little bit more complicated than they sound, because there are certain conditions which can be associated with Raynauds when we would be uncomfortable with that patient having HRT. So I think you would need to discuss that on an individual basis with your doctor. But per se, we wouldn't expect HRT really to make a huge amount of difference. There's been a little bit of interest in different hormones and Raynauds, but I'm not sure. I'm not conscious of any literature that specifically says that vitamin D is bad news.
That makes sense.
Okay, sorry about that.
Don't worry at all. From Tracy, we have, my GP advised that only calcium channel blockers can be the medication that they are prescribed. Should she question this? And if she did, how?
No, so calcium channel blockers aren't the only medication that can be prescribed. We have to be a little bit careful here, because it's interesting that there are very few medications that are actually licensed for the treatment of Raynauds phenomenon. And so we treat many patients out of what we call license with different medications. So some general practitioners are uncomfortable, which is very understandable about that. So while calcium channel blockers are first-line treatment, and they're the most commonly prescribed type of medication for Raynauds, there are other ones. And so, you should discuss these with your doctor. The evidence base is not as good as we would like it to be. There is some evidence base for calcium channel blockers, and there's also some evidence base for phosphodiesterase inhibitors. Clinical trials of Raynauds phenomenon are notoriously difficult to conduct, and that's one of the reasons why there isn't as good, hard evidence advocating different treatments as we would like there to be. But clinical experience dictates that many patients do benefit from calcium channel blockers and some of these other agents. So I think most general practitioners are happy to prescribe. So I would, if someone hasn't tolerated a calcium channel blocker, or if they've titrated it up to the maximum dose and it's still not effective, then it would be worthwhile, discussing that with your doctor as to whether there were alternatives or additional therapies that you could have.
From an anonymous participant, we've been asked, can anything be done to prevent finger ulcers forming, such as hand or nail care?
I think from the point of view of preventing digital ulcers, I think hand care is important. There isn't any, I can't cite you any particular study that's shown that, but I think it's only sensible that you protect your hands to the best of your abilities, particularly if someone has systemic sclerosis and contractures. It makes sense to try to avoid traumatizing the hands. But having said that, we all have to, live our everyday lives, and so there is always going to be an element of trauma. But I think it makes sense to try to protect them, and that's something that the occupational therapist can advise about, as hand protection measures. So from the point of view of actually preventing it, for treatment to prevent digital ulcers, the one licensed medication to prevent digital ulcers is bosentan, as I mentioned earlier. And this has been shown to confer benefit in patients with recurrent ulcers. It can reduce the number of new ulcers. It used to be very difficult to obtain, but it's now out of patent. And as I mentioned, there is an NHS England pathway, and bosentan is a part of that. So that's something that we would recommend.
Fantastic. It's good to know that there is at least one medication that can be accessed. From Nicola, we have a question which I'm actually going to preface with a question of my own. So you previously mentioned iloprost infusions, or iloprost, and I was wondering, before I ask Nicola's question, if you could very quickly explain what they are and how they work.
Yes, so iloprost is a type of drug called a prostanoid, and it works by widening the blood vessels. And it's probably, iloprost has a number of other actions, but the immediate action is to widen the blood vessels, and it does that very powerfully, but it has to be given, unfortunately, intravenously. So that's the main reason that we're using it in the context of severe Raynauds or digital ulcers, is for its effect on widening the blood vessels. And from the point of view of how long you would expect it to last, that's a very interesting question, because there is an immediate effect. I mean, a lot of people will find that, that they feel better by the end of the series of infusions, because it has improved the blood flow. Very often, if the reason that they were admitted was because of an ulcer, very often the ulcer is beginning to heal already, because you've improved the blood flow to a point when you're aiding ulcer healing. But a lot of people do seem to find that the benefit of iloprost is quite prolonged. I'm sure many of you here, have had repeated sets of infusions. And for example, if some people will have an infusion around, or set of infusions around the autumn when the Raynaud's is getting particularly bad, because it seems to have a carryover effect right through to the spring. So there are mechanisms of action that there is being research done on that we don't fully understand, but there does seem to be a more prolonged effect in a lot of people. And so the effect could last for several weeks, even longer in some patients. It's a little bit variable between patients.
Do you think that would vary on the conditions that a patient was exposed to? So if it was a very cold month, for example, would that impact it?
Well, that will impact on the Raynauds. Whether it impacts on the degree of efficacy of the iloprost is difficult to say. But I think there's no doubt that if people are exposing themselves to cold a lot, then yes, it will make the Raynauds worse.
From Heather. Heather has the start of an ulcer, which is in the very early stages and is currently not infected. At what point should she consider contacting her GP about it?
I think if anyone's worried about a finger lesion, they should seek medical advice. I mean, that would be my answer to the question, because I think sometimes it's difficult to know if they're infected. I think if you have a painful finger lesion, our advice is always to err on the side of caution and to ask about it. I think people do tend to, and many of you know this far more than I do, but I think people do tend to know their own fingers, and you will know, when something has reached a point when it benefit from an antibiotic or whatever. But I think if you're worried about it, I think any concern is an indication that you should seek medical advice.
Natasha asks, she has Raynaud's and systemic sclerosis, sans scleroderma, so skin involvement. Her skin responds very sensitively to cold and humid weather. Is moving to a country with a warm and less humid climate an option? Right.
Well, that's an interesting question. And I think the simple answer is that it probably would be an option depending on what one's priorities are. And I think there's actually no doubt that if you go to a nice warm climate, when you get a whole body heat, then that will be beneficial. But of course, that's probably not an option for many individuals. But I think I think being in a warm environment will help. And in fact, I do know some people who will spend part of the year, if they're in a fortunate position, they're able to do that in a warmer climate. But again, it's not something that we're able to prescribe, I'm afraid.
Not quite NHS recommended.
Well.
We've got a question from an anonymous attendee asking if you could please explain what calcinosis is.
Well, I'm very happy to. It's something that's of great interest to me. So calcinosis is the deposition of calcium-containing salts, usually just beneath the skin. And if you want to know the further details, it's a salt commonest as hydroxyapatite. So we don't completely understand why this happens, but we think it's probably in part related to poor blood supply. We don't think it's related to serum calcium levels, because a lot of people ask that, because they have calcinosis and then they're prescribed calcium supplements, and then they ask, is this safe? And yes, it is. It's nothing to do with the circulating levels in the blood of calcium. It's probably to do with some tissue damage at different sites. For whatever reason, these calcium lumps form. And they're very unusual, but they're a huge source of pain and problems in those people who get them. And so we need to understand more about calcinosis. But we are trying to develop new treatments for calcinosis, but unfortunately we're not quite there yet.
Thank you. Elizabeth says, many thanks for your talk. She was wondering whether extensive laser treatment could itself trigger an autoimmune flare-up similar to sun exposure.
Yes, that's an interesting point, but I think it would, there are always a lot of unknowns. I think it would be very, very unlikely that would happen. The dermatologists are always very careful. I mean, only small areas are treated at any one time. You are correct that the pulsed light dye laser can bruise the skin. And so many patients don't like it, because it can cause the immediate bruising, which is a bit unsightly, which is unsightly for a while. And, so it's not a treatment which is completely devoid of side effects, and that's one of the reasons that we did the study to look at the intense pulse light. So the pulse dye laser, which is the one that we use in the hospital, sorry if I got my terminology mixed up, that can cause bruising quite extensively. I think I've not heard of an autoimmune flare following on from laser treatment. I'll have to look it up now. You've asked the question, but I've not come across it.
Good to know, thank you. Michelle asks, how would you obtain the laser treatment for, I'm afraid I can't pronounce that despite the fact you said it,
Telangiectases. You would need to ask if you're under the care of a rheumatologist for systemic sclerosis, you would need to ask whether you could be referred to a dermatology department. Not all dermatology departments have access to pulse dye laser, and certainly it wasn't being used really much at all during the pandemic. So it's not always available to everyone, I'm afraid. But certainly where I work, we are able to access that through our dermatology department.
Thank you. Deborah says, thank you for the presentation. I have several autoimmune conditions and are currently on azathioprine. Would any of the drug treatments for Raynauds affect this? I'm sorry, but I've butchered that pronunciation.
So I think Emma's breaking up a little bit.
Oh, my apologies. Are you able to hear me at the moment?
Yes, we can hear you.
Okay, I'll repeat the question. So we had a question from Deborah who says, thank you for the presentation. She has several autoimmune conditions and is currently on azathioprine. Would any of the drug treatments for Raynauds affect this?
I think you would just need to ask your doctor. I mean, all drugs can have interactions, and it would, on the face of it, it would be a little bit unlikely, but there are a number of different drugs that are used for the treatment of Raynauds phenomena. So you would just need to check with your doctor that whatever he or she was considering prescribing didn't interact with azathioprine. But we use lots of treatments for Raynauds and people on azathioprine, so I think there would be unlikely to be a problem, but it's always best to double check.
From Jane, she says, thank you, that was very interesting. I have Raynauds, and when it occurs, I warm my hands back up under warm water or on a radiator. Is this okay to do, or could it cause further problems?
I personally think it's fine to do that, as long as everything's done, a little bit gently. And again, there are always different sides to the story. Sometimes, depending on the cause for the Raynauds, sometimes people can have a little bit of what we call neuropathy with Raynauds, and they might not be so sensitive to things. So they need to be very careful that they don't put their hands on a surface that was too hot or whatever, because that could not be good, and they might not sense that it was too hot. So I think as long as you're just sensible about it, then I think in most cases that's absolutely fine.
Leslie asks, could there be a link between celiac disease and Raynauds?
It's an interesting point, and celiac disease has been sort of associated with a number of different conditions. I think it would probably be a little bit unlikely that that celiac was related to Raynauds in most people. It's not a recognised cause of Raynauds phenomena.
Nicola asks, do you have any recommendations for managing hand swelling, please? Also, thank you for a great talk.
Well, management of hand swelling, really, we have to ask ourselves what the cause of the hand swelling is. So the first principle is to discover what the cause of it is, and if that's got something, a treatable background to it. Very often, and this isn't for you, Nicola, it's just as a general point, people with systemic sclerosis or scleroderma can have puffy fingers, and there isn't any immediate treatment, although some people find wearing compression gloves is quite helpful. So again, it's just something to ask your doctor, but the first thing is to really establish what the cause of that hand swelling is, because it might need a specific treatment.
Lynn asks, can you get Raynauds in the feet and toes, or is it just in your fingers?
Yes, very much so. You can get it in your toes. And in fact, it is one of the things that I should have mentioned when I talked about patient education. So thank you for giving me the opportunity to mention that point, which I forgot to do. Podiatry care can be very important in the management of Raynaud's and digital or finger and toe ulcers, because the feet are much less visible. So very often that means that they get a little bit ignored. And yet Raynaud's, as many of you know, can be very problematic in the toes. And if you have systemic sclerosis or a scleroderma and you go on to develop a toe ulcer, that can be a very significant problem. So it is important to recognise that problems occur in the feet. So nice warm socks and treatment of the Raynaud's in its own right, and seeing a podiatrist, especially if there's any suggestion that you might be developing an ulcer of the toe.
Okay. We've had a question through by email from a lady called Elizabeth, who explains that she has Raynaud's and currently takes medication, but she still gets 3 to 5 attacks a day. She's been told by friends that the Wim Hof method, which involves putting your hands into ice water over a number of weeks and training them, and she's asking, is that worth a try, or would she exacerbate her fingers and her Raynaud's by plunging them into icy water?
I'm sure opinions on lots of things vary, but I wouldn't recommend anyone with severe Raynaud's to put their hands in a bucket of ice water, I'm afraid. That would be my own personal view on it. I think we want to avoid cold exposure, not encourage it. That would be my view.
I believe Wim Hof is a slightly unique individual in his capabilities to endure cold temperatures.
Each to his own.
This will be probably the last 1 or 2 questions, and then we will wrap this up. But from Pauline, we have, can rheumatoid arthritis be related to presentation of Raynaud's in late 30s?
It's an interesting question. There's been quite a lot of discussion as to whether Raynaud's is overrepresented in people with rheumatoid arthritis, and also whether it might be more severe in patients with Raynaud's with rheumatoid arthritis than in people without rheumatoid arthritis. I think most people feel that the prevalence of Raynaud's is probably not significantly increased if you have rheumatoid arthritis. And so I think that would probably be my view. I mean, it is, of course, possible to have both conditions, because rheumatoid arthritis, unfortunately, is a common disease, and Raynauds phenomenon is common as well. So it's certainly possible to have the two together.
Thank you. And last but not least, we've got a very interesting question, which is, can I ask why clinical trials of Raynaud's are notoriously difficult to conduct?
Right. Well, there's different levels of answers. I could give you a very long answer about that, but thank you very much for the question. One of the problems is that they have to usually be conducted over the winter months, because if it's what we call a phase 3 trial, when we're involving quite large numbers of patients at a later stage of drug development, and you're giving the medication to someone for a period of weeks or whatever, then really you have to contain the study in the winter months, because otherwise it gets completely messed up by the weather getting warmer, and then everybody's Raynauds gets better. The study design is challenging because people's Raynauds, so that's one problem. Another problem is that people are very different in how they experience Raynauds phenomenon. And so a lot of studies of Raynauds phenomenon, for that reason, compare patients to themselves. So it has a so-called crossover design, so that you might have one medication for a few weeks and then the other medication for a few weeks. And that means that it's even more difficult to get it squashed into the winter months. And the third point, and something very close to my heart, because it's what we've spent a lot of effort in Manchester trying to help out with, is that what we call the outcome measures in studies of Raynauds phenomenon are very difficult, because it's actually extremely difficult to measure Raynauds phenomenon. And you might say that that's a rather simplistic thing to say, because why can't we just measure the number of attacks and ask us to plot how severe the attack is or how long it lasts? These things are actually quite complex. You know, it's actually quite difficult to measure attacks. And we try to have more, have some other measures, for example, looking at response to a cold challenge tests and so forth. And these two have actually got their own levels of complexity. So the main reasons are because of the environmental conditions, the studies are constrained usually to winter months. And secondly, because of the complexities of study design and how patients with Raynaud's vary so much amongst themselves. And thirdly, because of the difficulty in measuring the Raynauds phenomenon. So that's why it's been really very difficult. And there's a huge, what we call placebo effect in studies with Raynauds phenomena. I should have mentioned that initially. If you're interested in looking up the literature, this has played clinical trials of Raynauds. If you give half the people in the study a dummy treatment and half the people the real treatment, a lot of people on the dummy treatment will improve. Now, we know that that's the case in other walks of medicine as well, but for some reason it's particularly so in studies on Raynauds phenomenon. So it is very challenging, and I think for that reason, people who have been in drug development have found it very challenging.
Thank you for that. That was a very interesting final question to end on. So I'm going to draw this webinar to a close now, and I just want to say a massive thank you, Ariane, for your time today and for your expertise. You've answered some brilliant questions. It's been very interesting to listen to. So thank you very much.
Well, thank everyone. Thank you everyone for the questions. It was a really good, very interesting for me, and some things I'm going to have to swat up on and reply to your questions. So thank you very much.
I hope you all have a lovely evening. I'm going to stop recording now and end this webinar. Bye, everybody.